All right, good morning. We're going to get started. My apologies for our delay. Welcome to the Wilson Center and the Maternal Health Initiatives event on bridging the gap in women's health research. We're thrilled to be here today with such an incredible lineup of speakers, and I want to thank our partners at EMD Serrano, which is the healthcare business of Merck KGaA Darmstadt, Germany, for making this event possible. I'm Sarah Barnes, and I direct the Maternal Health Initiative here at the Wilson Center, and I will be moderating the discussion today. And for those of you who are new to the Wilson Center is a critical source of nonpartisan foreign policy research and analyses where we work to tackle global issues through independent research, open and honest dialogues, and actionable ideas. The Maternal Health Initiative is one of the 16 programs here at the Wilson Center, and we really work at the intersection of global health equity and gender equality and their links to U.S. foreign policy. And while our primary focus is indeed on maternal and reproductive health, we are so grateful for this opportunity to look beyond sexual and reproductive health today and spend the next 90 minutes focusing on health conditions that are unique to women, are more serious or more common in women, or that present themselves differently in women than in men. And of course, we'll look at how research, improved data, and increased representation of women in science can help bridge the gap in women's health globally. So a few years ago, the World Economic Forum created a coalition for investing in women's health that I was fortunate enough to be a part of. And our original objective was to prove the business case for investments in women's sexual and reproductive health. But after some time, we decided that before we could really meet this goal, we needed to go more broadly and look at women's health beyond reproductive health and to look at women's health across the life course. The McKinsey Health Institute was brought in at that time and in collaboration with the World Economic Forum published a really important report on closing the women's health gap earlier this year in early 2024. We have a McKinsey expert here, so I won't go into all those findings or steal any of that thunder, but I wanted to share one thing, and that is that women do spend 25% more time in poor health than men, and that data gaps underestimate women's health burden, which has a ripple effect on both innovation and investment in women's health research. So we hope today, through our discussion, we can learn a bit more about what separates the sexes when it comes to our health, what research is happening now that is key to progress, and the role of policy and investment here in the U.S. and globally. We wanted to thank everyone who already submitted questions online ahead of time. We got dozens of questions, which is really, really exciting. And we will also leave ample time for those of you in the room and for those of you who are watching online today to also ask questions of our panelists. For those who are watching online, please just note the text box underneath the video where you're seeing me speaking. That's where you can put in your questions, and we will do our best to incorporate as much as we can in today's discussion. Before we start the event, just a huge thank you to my colleagues at the Maternal Health Initiative, especially Dikshita Ramanarayanan, who's down here in the front, and Consolata Chikoti, who is still helping people come in who were stuck in traffic. Without them, none of this would be possible. I'd also love to thank in advance all of our speakers and your teams that really helped with the coordination for bringing you to the Wilson Center today. And I'm very much looking forward to having a very robust and impactful conversation. So now, without further ado, I would like to introduce our keynote speaker, Dr. Carolyn M. Mazuri. Dr. Mazuri is chair of the first ever White House initiative on women's health research, which aims to fundamentally change how the nation approaches and funds women's health research. Dr. Mazuri is also the Svungen Bildner Professor in Women's Health Research and Professor of Psychiatry and Psychology at Yale University. In 1998, she created Women's Health Research at Yale, the university's successful interdisciplinary research center on the health of women and the interplay of sex, gender, and health. Dr. Mazuri has served on the advisory committee for the NIH Office for Research on Women's Health, provided testimony to the U.S. Congress on the health of women, served on the planning committee for the first White House Conference on Mental Health, and was a fellow for the U.S. Congress's Committee on Oversight and Government Reform. She has also received numerous national honors and awards in recognition for her incredible work. You get the point. She's the perfect person to give our keynote today. It is an honor to welcome you to the Wilson Center. The floor is yours.
Good morning. Thank you, Sarah. And my thanks to the Wilson Center and EMD Serrano for inviting me to join you this morning. I want to first recognize the important work of the Wilson Center and its partners on many important global issues and express my appreciation for convening this Women's Health Research Summit because, in my view, women's health is a global issue. In fact, we just returned 2 nights ago from a trip to the Persian Gulf, during which Dr. Biden spoke to leaders there about common interests in women's health research designed to improve the lives of women. So today, what I'd like to do is provide a brief outline of some of the substance, the actions, and the achievements of the White House Initiative on Women's Health Research, as well as to speak broadly about the health of women in the U.S. As this audience knows, and thanks to the work of members of this audience, over the last 2 decades, we have made meaningful progress in studying the health of women and have clearly uncovered data that can be used and have practical application now. Nonetheless, despite the evolution of our research and important contemporary findings, as well as other important knowledge accrued over the years, oftentimes through clinical observation, the long-standing underrepresentation or exclusion of women in clinical trials and the continued need to understand sex as a biological variable have resulted in still knowing too little about how to effectively prevent, diagnose, and treat a range of health conditions in women, leaving women and their healthcare professionals without the tools they need to respond to a range of health conditions that, as Sarah was saying, either affect women uniquely, differently, or disproportionately. Also, I'd like to recognize the McKinsey report because that was such an important report and continues to be so important. And you have estimated through that, Dr. Burchuk, that the McKinsey report told us that although women in our nation, in the U.S., live longer than men, we tend to spend approximately 20% more time in poor health. As shown by other studies, not because women are less resilient, rather because women are at greater risk for poor health outcomes as a function of what we do not know. The result is that women are more likely than men in the U.S. to suffer chronic disease and disability, have co-occurring disorders, develop Alzheimer's disease, have autoimmune illness, live with acute and chronic pain, have a higher incidence of lung cancer not fully explained by smoking patterns, face high rates of mortality from diseases unique to women, such as ovarian cancer, and often highly debilitating conditions, such as endometriosis, and are still more likely to die following a heart attack. These gaps are even more prominent for women of color, older women, and women with disabilities. So the White House Initiative on Women's Health Research was launched by President Biden through a presidential memorandum in November of 2023, about a year ago. And the focus was really to build on the empirical foundation that is available to us and pioneer the next generation of discoveries that will close some of these research gaps, potentially over time, all of these significant research gaps on the health of women and improve women's lives. Also, as Sarah said, importantly, I think it's worth repeating, the goal of the initiative is to fundamentally change the way we approach and fund women's health research. The initiative has been, continues to be, led by the First Lady, Dr. Jill Biden, in collaboration with the White House Gender Policy Council, and I am honored to be the chair of the initiative. I think it's also important for us to all understand who the members of the initiative are. So the members of the initiative include the Department of Health and Human Services and many of their component parts like the NIH, the CDC, the FDA, et cetera. It also includes the Department of Defense, the Department of Veterans Affairs, the Department of Agriculture, the EPA, as well as the National Science Foundation. So all places in which federal agencies have health as part of their mission have been named as part of the initiative and have been participatory. And the first thing the president did in the presidential memorandum was to ask these agencies and departments to consider how existing funds how existing federal dollars can work harder to improve the health of women, and directed the members of the initiative to provide actionable recommendations for how they will advance women's health through policy and through programmatic changes. Throughout the last year, we have worked collaboratively and extensively with these agencies. We've also held listening sessions, roundtables, discussions with many different stakeholders from both public and private sectors, because we really wanted to understand the health focus of different stakeholders, understand their concerns. In addition, we have traveled the country, and Dr. Biden has gone to academic research centers and other research centers to understand what the kind of work is that people are doing and understand how they're meeting their goals. The outcome is that the initiative and its members have been highly responsive to both the presidential memorandum and also to an executive order that the president signed in March of 2024. That executive order directed the most comprehensive set of federal actions ever taken to advance women's health research. There is much to say about these documents and the work that has come from them, but in the interest of time, I'm going to make two broad general comments. First, in terms of funding opportunities, over the course of the last year, these agencies that I've named and departments have really stepped forward, and they have generated the opportunity to use nearly $1 billion of budgeted federal funds, and those have been committed now by members of the initiative. Again, in the interest of time, I'll only mention that these commitments come from multiple different agencies, not from a single place, but they certainly include ARPA-H, which, as you know, has, I hope, it seems like everybody knew about ARPA-H, and we have a funny story, Dr. Klein and I, about it. An Uber driver who commented during an Uber ride that he too was applying for an ARPA-H grant. But it was very well known and publicized well, and they received 1,700 applications when normally they receive like between 50 and 100 for any kind of call they have. And what they do is they help to fast-track transformative research for development and implementation. Also commitments from the Department of Defense in terms of an annual contribution, SAMHSA in terms of dedicating funds to improve women's behavioral health, and NIH, of course, which is launching a new NIH-wide effort to close gaps in women's health across the lifespan, and particularly to have a focus on women's midlife health. So that's the first broad comment about funding opportunities and what we've generated through the initiative. The second would be in reference to actions. What are the actions that are being coupled with this? Because in my view, that is at least as important as having the funds to do the work. And here, too, significant changes are occurring. Again, too many to name, but I'd like to give you just 3 examples. I'd like to start with the NIH, which announced back in November that there'll be new guidance and practices in effect in January 2025 to ensure that its ongoing commitment has not only the appropriate representation of women in their funded studies, but that research and data standards leverage each aspect of the NIH process to ensure that women's health is thought about at every stage of the application process, the funding process, from the time, whether it's called an RFA or a NOFO or whatever it's called as a request for applications, from that point all the way through to many points of interest that for us where things can fall through the cracks. The NIH has worked very diligently to ensure that this does not happen going forward and will implement these guidelines, as I say, in January. The FDA has made public in September of 2024 their new women's health research roadmap that I would recommend to you. It's a very well written and very informative document about science and innovation and building a roadmap for women's health science in FDA research activities. And then finally, the Department of Defense along with their announcement of funding, has made public a new policy in which they will be using SABV, sex as a biological variable, as a requirement in preclinical research, in translational research, and in clinical trials. So these brief examples give you some idea of how government-led research programs support essential research, and they really provide unique opportunities for discovery. We also have, coupled with those, the opportunity to translate empirical findings through things like the Small Business Innovation and Small Business Technology Transfer programs, as well as ARPA-H. In addition, however, it's clear that if we want to maintain and grow the pace of discovery and convert discovery into meaningful benefit, we must expand the sources of funding that promote innovation in women's health. This includes adding new sources of funding from the private sector, which means industry, nonprofit organizations, and philanthropy, through mission-driven efforts and collaborations to build research that benefits women's health. And again, as this audience knows, this has begun with regard to industry, for example. You will read in various news outlets like Forbes about reports of how the data are indicating that the number of venture capital-backed companies that relate to women's health has grown in the last year. In reference to nonprofits, I recognize the American Heart Association, which launched their own new Go Red for Venture Fund, which funds startups working on treatments for heart disease and more, including stroke, kidney, and metabolic conditions, mental health, and Alzheimer's disease. And in reference to partnerships, there's a recently announced $10 million funding opportunity from the Global Cardiovascular Research Forum, and $2 million of that $10 million comes from the National Heart, Lung, and Blood Institute. So that, we think, is a really nice example of a public-private partnership. So I'm going to start to wrap now, because I suspect I've used my time. But I did want to say that if we do not grow the scope and depth of women's health research, women will continue to have high rates of adverse health outcomes that inflict a personal toll on women and families, as well as a toll on the economy. However, if we do improve the health of women during the working years alone, as Dr. Burchuk will probably tell us, the opportunity economically is extraordinary. So in sum, we have shown in the past that we can alter the landscape of research to advance an ever-evolving science that improves health outcomes. And we now do have the data-based foundation, in addition to the scientific expertise, that can advance women's health. We have the capacity to discern sex-specific mechanisms for disorders and social determinants of health, each of which, every one of which, could become targets for developing more effective treatment interventions and prevention strategies for women and for men. And we have the opportunity to build on the momentum generated by the White House initiative, which in my view has raised the national consciousness on this issue. This is the moment in which we can expand our work together and across sectors to ensure that all of us are doing everything we can to close the research gaps in women's health, improve women's lives, and see the nation thrive. In closing, I thank you for the work that you all do and for caring about the health and lives of women. Thank you.
Thank you. Thank you so much. You've really wonderfully set us up for the remainder of the conversation. So thank you so much, Dr. Missouri, and thank you for your dedication to women's health and women's health research. Okay, now we're going to move to our panel, and I'm going to invite all four of you to come to the stage. We've got Dr. Irene Aninye, Dr. Carolyn Burchuk, Dr. Janine Austin Clayton, and Dr. Sabra Klein. And you can come up and get yourselves situated, and then we will start the presentations from each of you. And I will give a little bit of your background and bios. And just a reminder, if you're in the audience, you can be thinking about questions. We will have a Q&A, and we do ask that you ask questions during the Q&A, not just comments, because we want to make the most of the time we have with our panelists. And if you're watching online, please put questions into the chat. And again, as I said in the beginning, we did get dozens of questions ahead of the event, so I've already tried to incorporate them here. Okay, so let's get started. So first, welcome to all of you. Thank you so much, and thank you for braving the DC traffic this morning. Always something. So we're going to start by giving each of you a chance to talk a little bit about your work, and then we'll go into a discussion. And we're going to start with Dr. Caroline Morgan-Burchuk. Dr. Burchuk is an associate partner at McKinsey & Company, where she advises healthcare clients, including providers, state governments, and payers, on clinical strategy, operations, value-based care, social determinants of health, health equity, and home-based care. Dr. Burchuk also serves as an attending physician at Brigham and Women's Hospital and as an instructor in medicine at Harvard Medical School. So we've already talked a few times about the McKinsey report, so I'm just going to ask you to kick us off and give some of the highlights from this 2024 report, and thank you so much for being here today.
Of course. Well, thank you so much, Sarah, to you, Diksha, and the Wilson Center for having us. So I think I would frame the next 5 minutes as the business case for the moral imperative. And so Dr. Missouri has really set the stage for why do we need this, some actions we can take. And in my world, it's often very helpful to also have the business case for why. Whether or not we believe we should or need it. Did anyone make a business case for Viagra? I'm not sure, but I think we'll talk really focusing on sort of why this matters for women, individually for ourselves, for our families, for our communities, and for broader economies. So do I have control? Okay.
You've got it.
TLDR, it's a $1 trillion opportunity, and so we'll go into a little bit more the specifics of this. So as Sarah mentioned, this was a collaboration between McKinsey and the World Economic Forum, and the 2024 report, and we'll give a couple of snippets of preview into 2025. But one of the things that I want to be thoughtful and mindful of is that we will use the term women here while acknowledging that it is important, more research across a lot of the sort of the gender spectrum, but I'll use the word women in the conversation. So what was involved in this past year's report? So Sarah mentioned it was sort of a combination of collaboration, people coming together, and really looking at what is everything to date that has been said in the women's health space. So, 650 papers, 64 conditions, ultimately covering about 86% of the global disease burden. So we'll go through 4 myths. Myth number 1 that we've touched on a few times is that women live longer than men, so we must be healthier. And this gets at the point globally 25% fewer years of healthy life, and in the US, 18, almost 20%. So the next feedback or comment that I often get is, well, women live longer than men. So no wonder, yes, these unhealthy years, they're later in life, women live longer. Turns out that's not the case. Actually, most of these years of, we could say, disability or the women's health gap really focused in our working years. When we think of the conditions that really drive the women's health gap, they're the things that affect us often, as we were saying, things that affect women differently, disproportionately, or specifically. And these conditions, things like premenstrual syndrome and menopause, they affect many, if not most of us, and they happen when we are in our sort of prime working years. And there's often a connection, a correlation between sort of the broken rung of achievement for women and challenges that they face with their health. So around 20% of women in menopause consider leaving their jobs as a result of sort of the symptoms or effects of menopause that they feel. And to be clear, menopause is not a disease, right? It's not. This is something that happens to all of us who are lucky enough to make it to the age of menopause. And yet, it is something that causes nearly a fifth of women to sort of reconsider their profession, their career, and how they spend their days and their time. The other myth that we've talked about and Sarah alluded to is that women's health is sexual and reproductive health, when in fact that sexual and reproductive health makes up about 5% of the women's health gap. And these other conditions, differently, disproportionately, or women conditions that we think affect about the same, but as Dr. Missouri pointed out, we actually don't even know, make up the rest of most of the gap, so over 95%. And so when we think about what are conditions that actually have the biggest gaps, so I mentioned menopause, endometriosis, PCOS, other sort of conditions, this is highlighting the data gap. So let's walk through that a bit. So if we think about the women's health gap as there's a data gap, as we don't count women, there's a treatment efficacy and effectiveness gap, we don't study women, and there's a care delivery gap, we don't care for women, we don't include all women when we do care for them. This is reflective of the data gap. So in IHME data, which is what many of us use to or even businesses use to say, is this a good market to invest in? Should I create an intervention or a treatment? You have to use data to say, what is my addressable market? IHME thinks that women age 65 years old, about 30% have gone through menopause. I did go to medical school. I didn't learn anything about menopause in medical school, or in clinical training for that matter. And I still think that is likely incorrect, almost entirely incorrect. And yet we know that 80% of women are not documented, and then only 30% are even sort of counted or assumed in global data that they have menopause. Endometriosis, we know about 60% of women are not documented in PCOS. It's about 20%. On the flip side, and one of the reasons we highlighted these conditions these are conditions that affect the health span. So we think conditions affect lifespan, can affect your mortality, conditions affect the health span, affect sort of your day-to-day. And in these are health span conditions. These are not conditions that directly could lead to early preventable death. Yet for men, their health span conditions are very well documented. Benign prostatic hyperplasia, erectile dysfunction, these are things that are well documented, discussed with providers, and actually intervened upon quite regularly. Did learn about both of those in medical school. So when we think about these disparities in race, the gender health gap is even more pronounced when we look across races and ethnicities. So what I would say one of the biggest crises of my lifetime is the Black maternal mortality crisis in the United States. Since I started in medical life, it has doubled in the areas in which I have lived. And so I think that when I think about, is there one thing that is like a crisis, that would be it. And so when we look at these disparities across race, ethnicity, even more pronounced. The other idea is we talked about it's a niche market. It's not, right? When we think about diabetes has over 10x sort of, we say assets in the pipeline. So these are sort of things in development that may hit the market compared to a lot of these other conditions. 1 in 10 adults has diabetes, 580 assets in the pipeline. 1 in 10 women globally have endometriosis, likely more. And then there are only 20 assets in the pipeline. So as we think about these gaps, we talked about number 1, which was that treatment efficacy and effectiveness. We don't study women. Number 2, we don't care for women. We don't include all women in that care. And number 3, we don't count women. And so the treatment efficacy and effectiveness, we've discussed the assets in the pipeline. On the care delivery one of the most striking things to me was around clinical practice guidelines. Again, I mentioned that we don't learn as much in clinical training. OBs, 70+% of them within the last couple of years have learned nothing about menopause in their training. And one could argue there are a lot of reasons for that. But clinical practice guidelines, we looked globally across 9 of the conditions that drive over 30% of the women's health gap. We looked across 15 countries. About 9%, less than 10% of clinical practice guidelines had globally accepted evidence, not a random paper that has 12 reads, but like globally accepted evidence on evidence-based practice. And less than 10% of them did. And we looked specifically at things around gender differences in care and education, just not present, not in the United States, not elsewhere, and not across the conditions we talked about. So massive opportunity in how we train, educate, and then implement those guidelines. And what does this mean? It's about $1 trillion in global GDP. And so I'm getting the end notes from Dikshita. But so we'll end on this opportunity. And this is such a big number. It's hard to put my head around what is $1 trillion. But what I would say is, these bottom, the x-axis, it's fewer health conditions for each of us. It is fewer early deaths among all of us. It's increase in productivity when it means and matters the most in our lives. And it's expanded participation in our families, in our communities, and in our broader society. Collectively, that's $1 trillion. That's likely a far underestimate of what this is globally for women alone, just if we close the gap between men and women in healthcare. So with that, I will pass it on.
Thank you, Caroline. This was great. This is exactly what we needed to kind of get things started. So thank you very much. And I know that we'll come back to several questions from that beginning presentation. So now we're going to turn to Dr. Sabra Klein, who is a distinguished professor of molecular microbiology and immunology and co-director of the Center for Women's Health, Sex, and Gender Research at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on sex differences and the effects of pregnancy on immune responses to viral infections, including influenza and SARS-CoV-2, as well as vaccine efficacy and immunogenicity. Yes. She has also authored more than 175 peer-reviewed publications, significantly advancing the understanding of sex as a biological variable in immunology. So please, Dr. Klein, can you share with us a bit of the focus and the need at Johns Hopkins to have this Center for Women's Health, Sex, and Gender Research? It seems we've already started a little bit of that conversation. And then as an expert in immunity in health and disease, what do we need to understand the differences between the sexes?
Absolutely. Well, thank you. I'm thrilled to be here, and I hope to pick up a little bit where Dr. Burchuk left off, particularly this idea about a limited understanding of differences between men and women, or when we're talking about our biology, males and females. So let's talk a little bit about what my lab does, and I have a lab filled with students and fellows. I mentor, I teach, I train, so I'm coming to you from a different perspective. And what much of our research and the research of my colleagues, including at Johns Hopkins, are showing is that women tend to mount greater immune responses than men. Show our immune system anything. Maybe it's an allergen, like pollen. Maybe it's something like a virus, like what Sarah introduced, like SARS-CoV-2. Maybe it's your own self-protein. Give us anything and we will mount a greater immune response. And so that can sometimes be good. So if it's that vaccine and that vaccine antigen, which is just there to train our immune system, teach our immune system what something bad could look like should we get exposed to it, we'll mount a great response. What we'll end up with is memory. So the immune system, much like our brain, has memory. So if you've had a vaccine, if you got your flu vaccine this season or your COVID-19 vaccine, what's happened is you have immune cells circulating in your body right now that have memory. So that should you go to that crowded airport to get on a flight to go visit family and somebody is coughing and happens to have COVID, should you get exposed, those memory cells are there to start making proteins to protect you. And it turns out that those memory responses tend to be greater for women than for men. And it results in vaccines sometimes working a little bit better. Our data and data from others show that even among older adults, males just need more exposures. Maybe they need more doses. Maybe the way in which we prescribe vaccines should be different. Women may not need as many doses when we think about how many times you have to go and get vaccinated. These greater immune responses in women, They can be beneficial. They help us clear infections faster. So we do typically get over infections faster, which is why I'm often asked every fall to talk about man flu. And is it real? But the downside of some of that greater immunity is much like Dr. Missouri was pointing out, we're more likely to have inflammation, we're more likely to have chronic diseases associated with inflammation, including those autoimmune diseases, when your immune system is attacking yourself. Even chronic inflammatory conditions like inflammatory bowel disease, allergic asthma, just some examples of different tissues where inflammation can cause disease. I also, last point I want to make, and that much of our research shows, is that these differences between men and women in the immunity and in our immune responses and the functioning of our immune system, it's not stagnant. It's not that it's always the same. These differences, they change over our life course, typically being greatest during our reproductive years when things like our sex hormones, like estrogens and progesterone, which are in higher concentrations in females than males, or androgens that are found in higher concentrations in males as compared to females. When those differences are greatest, that's when we tend to see the biggest differences between men and women. So what does this mean for diseases? What this can mean for diseases is that autoimmune diseases show a tremendous female bias, and I'm going to go into a little bit more detail with you about that. On the other end of the spectrum, we tend to find that men experience many more biases in terms of incidence and mortality from non-reproductive cancers. So by non-reproductive, I mean if we move out of the prostate, out of the ovaries, and into tissues that are shared between men and women, men tend to have worse outcomes, and I'm going to talk with you about that. I work with infectious diseases. Some have worse outcomes in women, others have worse outcomes in men. Lack of funding contributes to why we often don't know the causes and the unique differences between how these different infectious diseases impact us. These are autoimmune diseases. I just have listed here, I think it's about 16 of the top autoimmune diseases. And pink is stereotypically female, blue stereotypically males, and what I hope you can see is that there's a lot of pink on this graphic. Women make up roughly 80% of all autoimmune disease patients. So when we think these are chronic diseases, these are diseases that last for a lifetime, women are suffering with these debilitating diseases more often than men. Women are taking medications for these debilitating diseases more often than men. So we can see women are also significantly more likely to have not just one of these autoimmune diseases, but to have multiple autoimmune diseases. So going back to these notions about living with disability, most autoimmune diseases are diagnosed when women are in their reproductive years, not later in life. I told you that men are more likely to die from non-reproductive cancers than women. Here are some data speaking to this. When we look at either the incidence of non-reproductive cancers or mortality, in this case, males are green, females are blue. We can see that both the incidence and the mortality are greater for men than for women, with many of these cancers listed in panels B showing incidence and C showing mortality. Behaviors, so gender-associated factors. Women are more likely to utilize healthcare. Women are more likely to utilize healthcare providers earlier during disease states than men. Absolutely, these factors can contribute. Lifestyle factors can contribute. But in many cases, we're starting to really understand, and there's an explosion right now in cancer immunology, trying to better understand differences in the immune systems of men and women, and how things like those androgens that are found in higher concentrations in men change the functioning of immune cells in the environment where that tumor is to make those cells not work as well, not make as many proteins, not do as good of a job to fight that cancer. And so with that, I wanted to just give you a few examples to hopefully start a discussion, understanding that I think we are going to have to learn more about understanding the etiology of these diseases. And in order to do that, we need mechanistic studies so that we can better treat men and women differently in order to protect them equally. Thank you.
Thank you, Dr. Klein. That was really wonderful. Thank you for setting us up so well so far for this panel discussion. So next, we're going to go to Dr. Irene Aninye, who is the Chief Science Officer at the Society for Women's Health Research. She steers SWHR's science programs to increase investment in research on biological sex differences and awareness of health conditions and diseases that differently, disproportionately, or exclusively affect women. Dr. Aninye's research background is in endocrinology and metabolism, investigated sex steroid hormone receptor action in development, reproduction, and disease. Can you please share a bit with us about the Society for Women's Health Research and how the research impacts policy, inclusion, and accountability? And welcome to the Wilson Center.
Thank you. Thank you very much for having me. Yes, it's the Society for Women's Health Research. We, in February, will be 35 years old, and so we'll be celebrating that particular anniversary. And we were founded on the premise that women were not being included in clinical trials and medical research. And this gap that we knew was happening in addressing health and disease, in understanding the sex differences and the hormonal drivers in health and disease, as well as these other conditions. And so at SWHR, we take a tripartite, I guess, approach, as you might call it, in science, education, and policy to address these particular gaps. And so I think about healthcare, and we all know that the healthcare system is not equal. There are health disparities that arise from biological factors, from sociocultural factors and influences. We know there's social determinants of health. There's also insufficient resources oftentimes can affect health and disease. And that comes through knowledge, clinical education, but then also being able to access these resources. And it can be affected by geography, it can be affected by location, it can be affected by various biases as well. And then there's the access to these resources and whether or not they are available to the most vulnerable populations and diverse populations of individuals, but particularly women. And so in women's health, we also see that it is not above these inequities and the stressors that the healthcare system sees. And I like to look at being able to tackle this from three various stakeholders. We have patients, we have providers, and we have policymakers. Patients are those who are in need of care. And they're not just women. Women serve as patients, but they also serve as caregivers. And more than 60% of informal caregiving is women. And they are taking care of their loved ones in their home. They're often, depending, especially in midlife, a sandwich generation, so in their immediate home, or their parents. They're also in the social community, serve as a gatekeeper and support for healthcare. And then you have your providers. And providers are not only charged to dispense care, but they have to discover it, study it, and deliver it. And so they are gatekeepers in ways. And a lot of times we think of providers just as healthcare providers and medical professionals, but researchers and scientists are also part of this. They are discovering these solutions and this innovation. Also in this is pharmaceutical industry, and they are a big part of providing care as well. And they are gatekeepers because their biases, their education, their experience, if you go to a healthcare professional who sees, 20 patients or women with endometriosis in a week or in a month, they're very familiar. But if you go to a primary care physician who only sees 1 or 2 endometriosis patients in the span of a month or 2 months, then they're not as familiar, and that affects the care that they're able to provide. And our third group are the policymakers. And these are not just the decision makers, but also the decision influencers. And so I like to put advocacy organizations and leaders in this space as well, because it is, I think a lot of times we consider these as very discrete groups. We have patients, we have policymakers, we have providers, but if you think about yourself in your own hat, you probably wear these three hats in some realm of your work, whether it's at home as women. We've seen the data on and on. I don't think there's anyone in this room who is not any woman in this room or who's watching this who has not had some encounter in the healthcare system where they've been challenged with either getting information, not knowing how to treat their condition, or being dismissed with their symptoms. And so we have that patient hat, we have the caregiver hat. The scientists and researchers and medical professionals in this room also wear that hat. And then we often find ourselves in the category that we least think of, but we do influence policy and decisions every day, whether we're leaders in our organizations, in our professional societies, or we are in government. But I wanted to really underscore in this space, and I know we talked about it, Sarah, a bit, that scientists and researchers have there's a great need for them in policymaking and accountability. In having these conversations in SWHR, one of the key things that we do, or in our work and our efforts, bring together these groups. They bring together different stakeholders. We have interdisciplinary networks. We are advancing these conversations at a national level, but then also we've had opportunities to take this into a global platform and have this conversation in the challenges and the successes that we see and the advancements in the United States, and being able to share that with other nations and other entities and organizations that are looking to learn from each other. I think that's one of the key elements that is often overlooked in ways. Every organization has their strengths and every organization hits their barriers. But one of the things that I'm really proud that we do at SWHR is being able to convene and bring them together so we can now amplify the voices and the efforts of the individual partners. We also take the opportunity to create new things in a space where we see there's a persistent gap. And so oftentimes having those transparent conversations, being able to engage in those spaces, whether it's a closed meeting or an open forum, allow us to tease through some of these persistent gaps and these challenges in the unmet needs of women so that we can develop either a toolkit or we can work with the professional societies in their developing guidelines or addressing some of these gaps. That for us, it's everyday work, so we're very familiar, and we often forget that outside of this space, it's not common knowledge, the challenges that women face and the gaps that exist in the healthcare policy and research space. And so I guess I can kind of stop there as far as that is concerned. Thank you very much.
Thank you. Thank you. This is wonderful. Thank you very much. And now we will move to Dr. Janine Austin-Clayton, who is the Associate Director for Research on Women's Health and Director of the Office of Research on Women's Health at the National Institutes of Health. Dr. Clayton is the architect of the NIH policy requiring scientists to consider sex as a biological variable across the research spectrum. Dr. Clayton has been instrumental in leading NIH efforts for the White House Women's Health Research Initiative, for which she serves as a co-chair for data standards and research methods. Can you please just share a little bit more about your role and the priorities of NIH's Office on Research for Women's Health in your personal work to ensure that scientists are considering sex as a biological variable? And welcome.
Thank you so much, Sarah, and thank you to the Wilson Center for all the work that you do and for organizing us today. And I want to acknowledge my fellow presenters and Dr. Missouri for her wonderful keynote. Theme for me is going to be connections here. And I'm going to start with data because that's what we are all about at the National Institutes of Health. And you don't need to read that small legend on the right. This is years lived with disability for females on the left and males on the right. And on the y-axis is age. So across the life course, you've heard from Dr. Burchuk, you've also heard from Dr. Klein, that there are differences in how diseases present in women and men. And although globally, women live longer than men, women spend more years of life with disability, as outlined in the recent McKinsey report, but also in painful conditions. And what are those conditions? You can just look at these beautiful colors and say the pattern on the left is not the same as the pattern on the right, and it differs by age. Dr. Klein, up in that light blue, is non-reproductive neoplasms. And so we can see older men with more of an impact with those non-reproductive organs and cancer. That pink, light pink, is musculoskeletal conditions. And you can see that, as Dr. Burchak mentioned, that biggest band for women is in the prime working years. So we know that health is more than about the number of years lived, that it is the life in those years, that we're all working hard to optimize. And when there's more life in those years, we can contribute more to our families and economies and society. So one of the ways that we do that is through the NIH policy that on sex as a biological variable, which in a nutshell states that we expect that sex as a biological variable will be factored into research design, analysis, and reporting for vertebrate animal and human studies, and that strong justification from the scientific literature or relevant considerations be provided for applications and studies that are proposing to study only one sex. This went into effect in 2017, and the 4 C's of SABV are listed here. We think that studying sex strengthens science by upfront considering how sex might affect what you're studying. So that's the first C. The second, collecting data related to sex, so make sure that your data are separate for males and females so that you can characterize your findings, analyzing that sex-based data, and then please report that information so we can all learn from those findings, whether a study is powered to detect sex differences or not. Every single study produces information and results that we can learn from. And we want to learn from every study, especially those that are publicly supported. So here's my other bottom line up front and a single slide that talks about everything and would frame everything that we're going to talk about today. This is the research continuum in the beginning. We're all trying to get to a place in the middle where there are healthy people everywhere. And we do that in our biomedical research ecosystem through the laboratory and the clinic. And we have this continuum where we have preclinical studies, we're intending to move to the clinic. We study animal models of human disease. We're studying them because we want to understand human disease. We need to account for the sex differences we see in human disease and diseases that uniquely, disproportionately, or differently affect women. In our animal models, in our cell studies, in our laboratory work, in the work that Dr. Klein does, this is a routine for every single student, trainee, or fellow that comes to her laboratory. This is thought of at the beginning. As you translate those findings into the clinic, when you identify potential therapeutic targets, you need to understand if those that drug or intervention that you're studying might have a different effect in males and females, might have a different toxicity in males and females, so we can avoid toxicity surprises later on. Accounting for it through the continuum will do that. And if you account for SABV, you're performing analysis and you're reporting those results, especially for the primary outcome measure, in your publications, in presentations, in abstracts, in posters, in papers, in websites, in press releases, in everything that is communicating information from biomedical research. Then those findings can inform the next study. Then somebody in this audience or a student in Dr. Klein's lab can put in an application to NIH to understand and study that potential sex influence. Is it a real sex difference? What's beneath that? And our interprofessional health education, be it medicine, be it dental, or our pharmacy colleagues, Dr. Burchak mentioned she didn't hear about many of these things related to menopause in medical school. I didn't either. And so we need to do a better job of integrating that. And so our training and education programs seek to do that so we can change the future of healthcare so every individual receives sex-informed, evidence-based care. That will improve care for men, women, for everyone. And then that will inform policy. So here's a specific example, and then I have one more slide after that. Menopause and midlife health is a topic that really deserves additional attention. NIH has a long-standing history of supporting research in this space with the landmark Women's Health Initiative, with the study of women across the nation. But we're learning more and more that this is a critical health inflection point for women. Yes, I think more than 30% of women over 60 are menopausal. The average age for menopause in this country is 51. But there is a range and there are many causes. But a woman who is 51 who shows up with new brain fog in a clinician's office, is that new onset multiple sclerosis? Right. Is that menopause? A woman that shows up with balance instability, is that middle ear disease? Is that something new with menopause? A woman that shows up and fell off her bike last weekend and has a fracture, a bad fracture, who's 51, is that osteopenia, osteoporosis? Is that just a bad break? And in addition, I'm having trouble seeing that one. Cardiovascular, thank you. Dry eye. Cardiovascular disease, there are big changes in the cardiovascular space around midlife. We know that lipid abnormalities start to become apparent. Is that menopause, or is there familial hypercholesterolemia here? So there are different things we need to consider. That weight gain, in particular adiposity, abdominal adiposity, but also visceral adiposity, organs, adipose tissue in your organs that you cannot see. What is that about? Is that about midlife, menopause, or is there something else going on? And then, of course, anxiety. Are those palpitations arrhythmia, or are they a new onset anxiety disorder that is being manifested in menopause? Hot flashes, the quintessential menopause symptom. Are you unfortunate to have a lot of those that might last up to 10 years? Or is there something else going on there? In actuality, we need to address every single one of these, not separately, but together, and through coordinated, interdisciplinary, collaborative, integrative approaches. We're able to do that because women don't experience one of those by themselves. And we are not pieces of organs and systems and tissues. We need a whole person approach to women's health care in general, but in particular with midlife health and menopause. And here's my last slide. I was so pleased by Dr. Carolyn Missouri's remarks, and it's really been my pleasure to work with her on the Research and Data Standards Working Group around SABV and other research and data standards. One of the steps that NIH took this year was to create what's called a Notice of Special Interest, or NOSI. It's kind of like a rider. And we tacked it on to virtually all of our parent funding opportunities. Those are standing funding opportunities that we have for research grants, center grants, training grants, fellowship grants, even our small business innovation grants. The institutes and centers identified over 175 women's health research topics they were particularly interested in. We published those with this Notice of Special Interest, and we said we are opening these pathways for you to apply for women's health research funding, because we realize they are so important, and here's our system, and we're making it available. So delighted to be here with you today and looking forward to the rest of today's discussion.
Thank you, Dr. Clayton. And I would just ask everyone, let's give a round of applause to all of these speakers today. That, from the start to this moment, you all have answered so many of the questions that I have and that coming from the audience, and you made it a way that we could understand even if we're not scientists here in the room. Thank you very much, Dr. Missouri, for being here today. So now what we're going to do is we're going to move into a little bit of a discussion. And I think given time, we're going to have it be a little bit more of quick responses to a couple of the questions, and then we'll move it to the audience. So get ready on the floor. But I do have a lot of questions, and as we said, this is one of the first times that we've really had a women's health research-focused discussion, so this will be one of many. I've realized there's a lot to talk about. One of the things that came in from the audience, and then we're curious about too, that some of you have touched on that I'd love to hear a little bit more, is just talking about diversity. So, we know, gender inequality and sexism are some of the core issues that create this women's health gap. But then when you couple them with racism, classism, ableism, heterosexism, or other forms of oppression, we can see that gap grow. So we have a lot of interest on how we're working to improve diversity in research teams and in study participants, and what has been being done to ensure that historically marginalized groups are also benefiting from women's health research and are involved as scientists, researchers, and participants in studies. And there was, so that's one kind of general question. And another person asked directly if when conducting clinical trials in the US or globally, wherever you are doing your work, what are the requirements, or are there requirements to ensuring appropriate representation of men and women and other gender identities in study populations? So the first question is more of a general discussion point on like promising areas of innovation and investment in women's health. To how do we ensure that women with diverse backgrounds are adequately represented? And then are there actual, rules and regulations about inclusion within study populations? Who would like to go first? Dr. Clayton, I see you moving to your mic. Go ahead.
I can get started. That's a very far-reaching question.
They all
Absolutely.
are. Sorry, in
So,
advance.
diverse experiences lead to diverse perspectives that result in different ways to address problems. You asked about teams. Mm-hmm. We have challenges in society today. We need as many perspectives coming to the table to converge on problems, to address issues from a different vantage point. So that is really important and is the crux of interdisciplinary research, which is an approach that is so important to women's health. That means we need to consider biology, we need to consider social factors, we need anthropologists at the table, we need engineers at the table, we need people who have different lived experiences at the table to maximize answering the tough questions. Mm-hmm. We do have research programs specifically focused on underserved, underreported, and underrepresented populations of women. And we recently published our U3 Health Data Book where we highlight the data. This is about understanding what the health needs are for all women and how they differ, whether they're rural, in a rural location or an urban location, whether they have disabilities, what those disabilities are. We parse out those multiple identities, and we know that people are affected by many different circumstances, social determinants of health. So we have that data available so we can understand where the needs are. And we know, for example, there's a huge need in terms of rural locations where obstetric care deserts are substantial. They're in urban areas as well, but substantial in rural locations. So that's a couple of examples.
Thank you.
I will add, joining you from a university setting where I co-direct a center, we do think about this a lot, and we do a lot of work at the university level to promote greater diversity in our teams and greater consideration of enrollment of patients with diverse backgrounds and identities. One challenge that we often have is that in many cases, those who are the most marginalized tend to be the most questioning of medicine and of research. And so I do think there's a gap there between the researchers' desire to enroll very diverse populations and trust in the medical system of those people and their lack of desire to sometimes participate in our research. So I do think that gap needs to be addressed.
Thank you.
If I can quickly add to Dr. Klein's point, you have to be intentional. And so you said you think about it. You have to be really intentional. When we talk about patient-centered policies, patient-centered care, you're thinking about the end person in mind, and that should determine every step that you take. How much, when you're designing a study, it should really consider the women, the different populations, the diversity of those backgrounds, because if not, you're going to create something that's not accessible or something that does not apply. And we've learned from that mistake in the past when we look at research on men versus women. And so now taking it to that next step in different subpopulations of women and making sure that we are very intentional in our investment, not just in our time. But when studies, I recognize the challenges are there. I mean, we're not saying when you want to recruit, there are challenges, but we can't stop. And I think that is the crux of it. You can't stop trying and, continuing to put forth effort and figuring out how can we recruit better? Do we need to open it back up? Do we need to spend more time in advance thinking about this and preparing for this, engaging the community before you open up a study, involving gatekeepers in that work? And so that, I think, is as long as you stay patient-focused and patient-centered in your approach, it will get you one step closer to success.
Great.
I'd like to add one more comment about the impact of sort of what we're not doing, maybe. We looked recently at all phase 3 clinical trials for the top conditions that affect women's lifespan. So ischemic heart disease, breast cancer, cervical cancer, things like that. There's not a single, then we looked at resulted trials. There's not a single trial with results that would have anywhere close to the impact on mortality that eliminating disparities would. And so one of the things is, so what are we actually studying and what is the impact of that? So things in development, when we look at cancers, they look a lot at progression-free survival, overall survival. Again, nothing would impact mortality the same way as if we invested in eliminating those disparities. So the next question is, so what do you actually invest in and what do you actually study? Much more advanced researchers on this panel, one of the things that we looked from the data show us about lower income and lower middle income countries, though, is that most of the trials aren't happening there, right? And so I think two things. One, it's expanding the primary investigators for these conditions, those areas. Because when we think about treatment efficacy, there's also treatment effectiveness, right? Is what does this really look like in practice and in different communities? And we honestly have no idea. And the next thing is, I think, a lot about anecdata, these areas of sort of spike where we see some interesting outcomes. And one of the things that I'm interested in is kind of, we have evidence-based practice. Well, what does practice-based evidence look like? Can we look to some of these areas that have organically, especially in sort of communities that may not have had access to the same trials or research or medications or interventions, when they do have good outcomes, what's driving that? And so thinking about more, I love evidence-based medicine, evidence-based practice. Where are there practices where we can actually find some evidence and we can look and see where they can guide us in ways that could be really helpful and meaningful in areas we haven't studied before?
Thank you. Before we turn over to the audience, so we have a lot of questions and interest, and we've talked some about menopause, endometriosis, but we have some questions from online on those, and then one on mental health. And so I'll just ask that maybe one person answer each kind of these, and then we'll move to the audience. So you already talked with the McKinsey report, really highlighted menopause and endometriosis. So if you haven't read the report, do go look because it's really interesting. But it states, some 450 million women worldwide have menopause or perimenopause symptoms, and some studies have found that as many as 190 million women are suffering from endometriosis. So these are, very prevalent conditions. But despite this and the growing aging populations, menopause research continues to receive minimal funding. And for endometriosis, there can be a 4 to 11-year delay between the onset of symptoms and diagnosis, with as many as 6 out of 10 cases going undiagnosed. So here are some of the questions. And so in some circles, menopause seems to be having a moment. Are any of you finding that there's more attention in the research, more comfort talking about menopause, more understanding of menopause, more investment? And then a similar question to endometriosis, but more so on, have there been any improvements in attention to diagnoses and why? And Dr. Clayton, you alluded to some of this, but why is it so difficult to diagnose? And this isn't just in the U.S., this is looking globally, that people sometimes have a decade waiting to be diagnosed. So who would like to talk about menopause and who would like to talk about endometriosis?
I'll do menopause.
Okay.
Caroline, you can do endo?
Sure.
Okay. So for menopause, we are excited that for the first time last year, we were able to report on NIH funding on menopause. We actually weren't reporting on that because we didn't have a way to categorize that research. So I think it is really important for us to be transparent about the research we're funding. And so that data is available now so we can track the number. What I do see is multiple institutes are working in a new way because there's been increased attention. And so elevating the visibility of women's health and menopause in particular has been very useful across sectors. And so we have now a chronic diseases notice of funding opportunity that specifically highlights female-specific chronic diseases, which, as I mentioned, menopause is the health inflection point for a chronic disease. Menopause in and of itself deserves further study and understanding. And I do think that this will grow over time with sufficient investment.
Wonderful.
Yeah, so on endometriosis, a few things. One, a metric that is kind of new to us that we've been working on is dollars per DALY. So if we think about how much funding basically what you want to say is how much funding is going per the impact of this on women's lives around the world, right? So their disability adjusted life year. The dollars per DALY for endometriosis is, I think it's less than 10. I mean, it's very, very small. In comparison, HIV, which appropriately affects the lifespan, is a big pandemic of our generation. It's $700-800 per DALY. So when we think about dollars per DALY, it's an indication of really low investment. And this is across public-private sector, essentially worldwide databases of where is all the funding going. NIH is included, but so are Gates and others. Really low for endometriosis. And so when we think about a few things, so as the positive too, I think one is we talked about counting. So since there is an awareness of the data gap, what we can advocate for is how do we extrapolate what we think those numbers are. So the numbers in endometriosis and WHO versus IHME range from 60 million to 190 million, and no one really knows because it's probably undercounting. Mm-hmm. And so I think if we want to de-risk our investments, which means like how many people could this really affect, and when we start to make that business case, we can use our instincts to start to extrapolate to what the quote real numbers are, or more accurate numbers, to help sort of de-risk those investments and encourage investment into the space. The second thing is on diagnostics, the NIH is doing some really cool stuff in endometriosis. I think the gold standard diagnostic is laparoscopy, which doesn't make sense for most people. So often it's clinical diagnosis, even though that may not be technically the 100% way to do it. But there must be other ways. Are there sort of other sort of signatures or that we can do? And the NIH has been developing a few of those, which is very cool. Some more to come. And then I think the last thing is girls. When we also looked at pediatrics education in the space, it's almost nothing, right? I think there's a real hesitation of pediatricians to venture into the adolescent sexual and reproductive health space. Endometriosis is probably not a disease of adulthood. It's probably a disease of adolescent girls. That is when it first presents and evolves. And so the last thing I would say is extraordinary attention. I mean, if I would say what is 2025, for me it's like the year of the girls, right? We need to start earlier and younger at identifying, recognizing, and supporting girls before they ever get to the point where they have lesions and infertility and pain that they're getting treated because it's so now a really big problem. So that's sort of a list of.
Dr. Anye, I know I said just one, but I know you have a lot of expertise in endometriosis. Did you want to add any?
It's similar to what Dr. Burchuk was saying. The teens and the adolescents are really the age that we need to start to look at and pay attention to. And it actually links even to the menopause because it's a driver. These earlier ages set us up in our health when we're younger, sets us up for health when we're older. And so a lot of the challenges we see during menopause and during that transition are because there were things that were looming or already budding earlier in life, and these various sex differences in our disease. We see this stress test during pregnancy, we see it during puberty, and we see it during the menopause transition. Mm-hmm. So they're really all linked, and it goes back to what you were saying with the wheel with menopause. These conditions aren't in silo. These symptoms and diseases, they're not presenting just one. You have multiple ones, and I think that also is what leads to the challenges of being able to diagnose. They're very ubiquitous as far as the types of, you have pain. Well, where's the pain? It's back, but then it's your stomach, it's your abs. it's just all body. You have the bleeding, heavy menstrual bleeding, can be fibroids, can be adenomyosis, it can be endometriosis. So there's a lot of these, a lot of symptoms that have a lot of overlap. And really investing in finding out those root causes will help us to understand how to tease out a lot of these comorbidities, particularly not just for endometriosis and gynecologic health, but whole body health.
Amazing. Okay, thank you. Thank you. People on the floor here, will have my colleagues will get microphones. So if you have a question, raise your hand. And while they're doing that, I'm going to ask a final question that came from the audience. It's a big question, so we might not have time to really digest it, but we'll start. As we advance our understanding of women's health, how are you working to prioritize research that explores the intersection of hormonal changes, reproductive health, and caregiving responsibilities and addresses the mental health challenges faced by women at every stage of their lives? This might need to be a 2025, all-day discussion, but if anyone wants to just give a minute response, Dr. Klein?
So going back to this notion of diversity in teams, I think for many of us in the research space, we're seeing the diversity of our teams grow so that you've got clinicians, biologists, social scientists working together to address the holistic nature of questions like you just asked. So, in many cases, what we're also starting to do is combine the quantitative, so we've talked a lot today about quantitative research. How do we count? How do we count dollars? How do we count incidence, mortality, immune responses? But there's the qualitative side, and social scientists are bringing that to really address lived patient experiences and what are some themes that we can gather from that. So we're doing that in the research space.
Thank you. Wonderful. Okay, to our audience in the room, who has a question? Go ahead. And you can just introduce yourself and then ask your question. Thank you.
Hi, my name is Amal Shabazz. I'm a PhD student in bioengineering at the University of Maryland, and my project is focused on the intersection of women's health and regenerative medicine, and I hope to be able to continue to pioneer solutions in this area. So my question was geared towards students in this area. So many of the therapies in this field involve the use of cells or materials or biological components that may not be affordable for many of the patients that we're trying to treat. So I'm curious to know, what are your opinions on how we can balance innovative solutions in this area with equitable treatments that can reach the end population that we're trying to treat?
I would say looking at how you can scale is very important. The other, with every solution, think about minimalism. Even as you're working on a complex problem, thinking your lab, you still have to think about what are the least amount of resources I can use to be able to do this experiment. And I think if you come with that perspective and kind of seeing what we can pare down when you optimize, also looking at that can begin to help address some of those challenges of price and cost, and helping to tackle access for those that don't have that level of resource.
I'd also add that we collaborated with the Gates Foundation to identify 50 high-return R&D opportunities for the health of women around the world. And that group, this international group of key interested parties, identified areas that they think are poised to move forward the next 5 years in low and middle income country settings, as well as in low resource settings elsewhere. So taking advantage of that knowledge about gaps that have been outlined is one strategy as well. And thinking through, as Dr. Anine mentioned, the minimalist approach in the way that something that could work in a lot of different settings, perhaps for different reasons, but would work in different settings, may help you to get more interest and uptake.
Dr. Clayton, that's the Women's Health Innovation Opportunity Map?
Yes,
What's
thank
called?
you.
Yes.
From the Innovation Equity Forum from last year.
Any more questions from the floor? Oh, no? Okay. Then I will ask a question, and this is a kind of a great question actually to wrap up with, but in your opinion, what does the future of women's health research look like, and what milestones would indicate real progress? Who would like to go first?
I'll go ahead and start. I think real progress would look like all studies, all research studies, reporting the comparison of men, women, even gender minorities in their studies, and have knowledge beforehand, so a priori knowledge of the differences in what the literature states.
You stole mine. I was going to say that. I think the future is bright for women's health because of events like this and our recent federal focus on the health of women and sex differences and the engagement across multiple sectors. The data are available. The data are being generated, but data is not knowledge. Data needs to be interpreted to become evidence. Clinical guidelines need to be informed by sex and gender considerations. So we need to continue to move forward and take this work to the next level in a collaborative and coordinated and very intentional way as we move forward. What does success look like? Multi-sector collaboration converging on the health needs of today's women in a way that puts science to work, puts data to work, puts technology to work, and puts innovation to work to drive rigor and equity. What does that look like on a practical level? It means that you automatically consider SABV. It should be as automatic as looking right or left before you cross the street. It should be as automatic as stopping at a stop sign. It should be as automatic as stopping at a red light. So that's a milestone. If every paper has the data, if every set of data is disaggregated by sex routinely, we'll just learn so much more.
Thank you.
Success is maintaining the momentum. I saw this year, particularly with the White House initiative, there were a lot of spaces that never considered women's health that began to invest in it. They started, like for example, the NSF, looking at engineering in women's health. There was, various agencies, but not just agencies, but foundations as well, that came into this space. We've been working in this space for some time, but it was great to see that as eyes were opened, they actually wanted to commit. And for me, I think that milestone and that progress is maintaining that momentum and having more moments like this where we can have those aha moments. When I tell someone Alzheimer's disease is predominantly in women, they're like, really? And then when they actually think about it and they think of all the people they know with Alzheimer's or dementia, most of them are women. And so creating those aha moments and getting new partners to the table bit by bit, year after year, so that it can help to sustain the momentum.
Thank you.
So success to me is closing the women's health gap and being able to measure that progress over time. And so one of the things that we've been working on with the Global Alliance for Women's Health is this women's health impact tracking platform. So what are the metrics that can actually look at closing that data gap, closing that treatment efficacy gap and effectiveness gap, closing the care delivery gap? And so I think for me, we've spent the last year or two, it feels like stakeholders really in the last couple of years have come together to identify, quantify the problem. And progress to me is that those quantifying numbers actually diminish over time. It's not the answer, it's not how we get there, but I think success to me is being able to look and say what we are doing is actually having impact at broad, significant levels. And I think with all of the women here and many men too, and that this is not only possible and achievable, but it's something that we will do and we must do.
Thank you, and I think we'll close on that very uplifting and positive note. Thank you, Dr. Burchak. Thank you, Dr. Anine. Thank you, Dr. Clayton. Thank you, Dr. Klein, and to Dr. Missouri, who is here. Thank you so much for all of your commentary and really for breaking it down for all of us who aren't scientists to really understand what we need to do to help close this women's health gap in research. And so for all of you, we will have a recording of this event. It'll be available within 24 hours. We will also in the new year be putting out some highlights from this conversation, and we will continue the conversation going forward. Please reach out to us. I know so many of you already put in questions, but reach out if there were certain things that resonated with you. I know a lot of you were really interested to learn more on the maternal reproductive, sexual reproductive health work that we typically do. We're hoping in 2025 we'll really look at the intersection of these conversations and how they come back to the core work of the Maternal Health Initiative. So thank you all for being here today, and thank you for those online and to our wonderful speakers. Really appreciate it. Thank you.